Well, again, thanks for inviting me. Sorry I'm late, but to those of you who were here last year, you probably remember that gave a similar talk, and Joe asked me to kind of give it an update why TAVR may not be the Holy Grail and why surgical AVR is not quite dead. So let's see which one we get next. So as many of you know, TAVR is basically placing a percutaneous valve mounted on stent through the femoral artery. It was first implanted in 2002, and it was used in patients basically who were inoperable. Obviously, it has a lot of advantages over surgery. Anytime you don't make a cut, patients tend to recover faster. And we need to remember that the current FDA-approved indications for TAVR, for commercial TAVR, where most of you guys, I presume, work, and where most of TAVRs are going to be done, is still for severe symptomatic aortic stenosis in either inoperable or high-risk patients. And that's the FDA criteria, that's Medicare's criteria to reimburse it. The moderate risk patients are only being done at study centers. Obviously, I can tell you just from looking at our community in St. Louis, those guidelines are not strictly adhered to. The routes of access are transfemoral, obviously, going up through the groin, just like a cardiac cath. Transapical was the other option in the early days of TAVRs, where you just make a small incision, go through the apex. And later on, transaortic was done in patients who've had a lot of vascular disease. You can't get up through the femoral artery, and you make that through either a tiny sternotomy, direct aortic puncture, or through an axillary approach, cut down on the axillary artery. The transfemoral achieves probably the least amount of invasiveness. Initially, it was always a cut down. Now, pretty much it's all percutaneous. Transaortic, again, is less common, and transapical is the only antegrade approach and is probably going to be soon a pretty much historical approach. And we'll see that a little bit later in the talk. There are two commercially available valves that are available in the US. Edwards came out first with their SAPIEN. It's a bovine pericardial valve mounted on a stent, and it's balloon expandable, and it's low profile. You can see the height of it compared to Medtronic's version, which is a porcine pericardium instead of bovine, again mounted on a frame, but the frame is nitinol, so it self-expands and does not need balloon dilation. Initially, the Edwards was requiring much bigger sheaths, but now pretty much they're all can be implanted through a 14 French sheath and require a 5 millimeter femoral artery, so pretty small delivery devices. And this is the trial that kind of got TAVR off the ground, is the partner trial where Edwards looked at patients with severe AS and broke them into two groups. Non-surgical patients were cohort B, and those were randomized to either transfemoral TAVR or medical therapy. And partner A was the ones who were operable but deemed high risk, and they were randomized to either transfemoral versus surgery or transapical versus surgery. And what partner showed in cohort B, that inoperable, is that if you put a valve and relieve aortic stenosis, you're going to do better than medical therapy. Patients who had standard medical therapy, over 50% of them were dead at 2 years, so aortic stenosis is obviously a pretty lethal disease. And if you can improve it in any way, you're going to do better than medical therapy. Cohort A were the patients who were operable but at high risk, and basically showed equivalent results at 2 years. Medtronic came afterwards. They were a little bit behind Edwards, so they started their own trial called the Pivotal Trial, and they didn't randomize people who were inoperable, so they weren't trying to prove that TAVR is better than medical therapy. They were trying to compare TAVR to surgical AVRs. And they actually showed that TAVR was slightly better than surgical AVRs in patients at high risk at 1 year. So you see the difference is pretty small, but TAVR was better at the end of 1 year. So is surgical AVR dead? And I say not so fast. Well, why did I say that? Well, aortic valve disease is a very common disease, and we're getting an onslaught of aortic stenosis pretty soon. We know it's underdiagnosed, and when you look at patients who are over 75 years of age, 1 in 8 people will have some degree of aortic stenosis, and up to 3% will have severe AS. And as the average age of patients in the US and across the world increases, we're going to have a lot of people with aortic stenosis. And you can see the onslaught of older people coming down the pike. And 2020, 2024, and you look at this group, 75 to 85, we're going to have a lot of aortic stenosis. And this was our experience at WashU a few years ago when we were starting doing some of the partner trials. We were one of the partner sites. And when you look at the breakdown of our surgical AVRs, if you looked at high-risk patients in the yellow, and you say, okay, those patients are gone, so we've lost 11% of patients. Now, if you take the next category of moderate-risk patients, you say, okay, those are all gone to TAVRs. You lose another 25, but you're still well over 50% patients will still receive surgical AVRs. At least in our experience, it's still the dominant form of valve replacement. And surgical AVR is good. We're good at doing valve replacement. This is data from quite almost 20 years ago, 95 to 2005. Our mortality rate keeps going down every year. A lot of patients, 90% of patients post-AVR are living in the Aortic Heart Association functional class 1 and 2, but 30% of patients were deemed not surgical. So there's a population that needs TAVR. And if you update that results from, this is STS data, 141,000 people who had AVRs. If you break it down from 2002 to 2010 in 2 5-year increments, you see that patients who have a STS score of less than 4%, their actual mortality is less than 2%. The moderate risk group, their actual mortality is about 5 to 6%, and it's getting better. In the high-risk group, you can see that between the early in that 5-year period versus early in the 10-year period versus later, our surgical AVR outcomes are getting better. So will TAVR be the first valve of choice? In my opinion, it won't be. And let's talk about some of the ugly sides of TAVR. Everybody talks about, well, it's maybe better than surgery, it's equivalent to surgery, but there's some ugly points. Stroke rates, AI, pacemaker requirements. We don't know anything about the longevity. We know the cost is quite expensive. So just go over a few things. This is from published in Circulation 2014, looking at multiple studies reporting on TAVR, looking at stroke rate reported by the study. And they're in the, they're not bad, in the order of about maybe 2 to 4%. A few studies higher, a few studies lower, but it's really not bad in an older population. But then when you look at cerebral events by gated MRI, you see that 2 to 4% clinical stroke is really masking rates of cerebral ischemic events that are in the 60 to 80% range. Out of these studies where they did MRIs post-TAVR, there were 2 studies that looked at surgical AVRs and did MRIs after them. And you can see that, and those are represented by these 2 red things and 2 red bars. And surgical AVR just has less hits, and that's what you would expect. Obviously, there's multiple sources of embolization during TAVR, both when you're passing your catheters, you're passing whoops, went a little too fast. When you're passing the catheter up, when you're deploying the valve, doing the balloon valvuloplasty, and people who are a lot of cardiologists will say, well, we're getting better. Our catheters are smaller. Our guide wire system, delivery systems are better. But when you look at Doppler, transcranial Doppler, of when these hits are occurring, when you're passing the valve, the wire, the balloon valvuloplasty, where you're passing the valve, those are fairly small hits. The hits are occurring mainly when you're positioning the valve. You're moving that stented valve across the native valve, and when you're deploying it. And those still have to occur no matter how small the delivery devices are. And you have to remember that TAVR is really a TAVI, so we're leaving the native valve behind, and all that calcium can create some areas of stagnation between the stent post and the calcified native leaflet, and that can lead to prolonged long-term embolization and strokes. And this is, again, the report in Circulation 2014, comparing TAVR and surgical AVRs, and you see that they start off higher and continue to go up higher in terms of rates of strokes. What about AI? Is it the Achilles heel of TAVR? Does it affect long-term mortality, and what does it do to our heart failure rates? Are these patients doing okay after a TAVR? And obviously, leaks can occur from multiple events. You can undersize the valve, you can put the valve too high, too low, or the native valve can crush the stent, essentially, and deform the valve a little bit. And those things have occurred when you look at the MRIs and CT scans. You can see valves that are crushed and not deployed as they should be. But, things have gotten better. There's a lot of ways of simulating the native valve, getting the both the deployment angles perfected and better sizing. But AI is a problem, and you can read the New England Journal article where PARTNER trial was presented. It says that paravalvular leak was more frequent in TAVR and was associated with increased late mortality, and that's in the original TAVR follow-up study. When you look at, and that's PARTNER 1, the cohort A, where they compared high risk to surgical AVRs. And what you want is you want to have the yellow and green bars. That's no AI or trace AI. You can see that surgical AVR, most of the patients are either net none or trace AI. And even at 1 year, most of the TAVRs, at least well over half of them, have at least mild, moderate, or severe AI. And that makes a difference to outcome. So when you plot here on the mortality curves, you plot it with AI, and you see in the top two curves, that's for paravalvular leak. If you had none or trace, you do better than if you have mild, moderate, or severe. So even mild AI does not look good favorably for a patient with aortic stenosis who has a TAVR. And then if you have no paravalvular leak, but the valve is deformed, and you have valvular aortic insufficiency, the curves are pretty much the same. If you have anything beyond trace AI, you're not going to do as well long term. This study looks at the route of deployment. For some reason, transfemoral deployment seems to create more AI. And both in the balloon expandable and the self-expanding valves. And again, we're moving more towards transfemoral approaches instead of all the other approaches, because patients recover faster and it's basically a puncture. But for some reason, transfemoral approaches do have more AI incidence. And the same authors again looked at in circulation at mortality, and you see if you have 0 or 1+ AI, meaning trace, anything over 2+ or higher, mild, moderate, or severe, your mortality rate is much higher post-op. And this is a study from Germany. Dr. Moore looked at what happens to patients a year out from surgery. Obviously, we want them to be alive, but then if you're alive, have you had symptomatic relief aortic stenosis? In post-surgical AVR, if you look at the pie chart, about 14% of patients remain in class 3 or 4 heart failure. That's the orange and the red. Post-TAVR, about a quarter of patients who are alive are still in heart failure. So we relieve the aortic stenosis, but we haven't really made them better. And that's probably because of the AI. What about conduction abnormalities? Is that a problem? We didn't think it is, but initially, well, we saved them an operation, we fixed the aortic stenosis, but guess what? Grandma has a pacemaker now. Is that a bad problem? Well, it is. The core valve, the Medtronic valve, 60% of those patients have either bundle branch block, that was new, a left bundle, or complete heart block requiring a pacemaker. The Edwards has less initially in the PARTNER 1, but they improved the valve to try and improve perivalvular leaks. So the newest Edwards valve is a SAPIEN 3. They gave it a little bigger skirt, extended it into the ventricle, and now their pacemaker rates are going up and up. And we know that chronic RV pacing is not good for ventricles, both in EF and for survival. And this is why anatomically patients have problems with TAVRs. This is a left ventricle fillate open. The conduction system, the left bundle branch, it sits right under the aortic valve. So when you deploy a stent that has to go through the annulus, it kind of compresses the bundle and creates left bundle branch block, which is a problem. So here's a presentation from TCT, the big cardiology interventional meeting last year. They looked at 2,500 patients who had a TAVR. 500 of them were in the PARTNER trial. 2,000 were at continued registry. 30% of patients had a new pacemaker at 30 days. At 1 year, patients with new pacemakers or left bundle branch block had a higher mortality rate than if you ended up with that operation without a pacemaker. At 1 year, patients who had a permanent pacemaker had a lower EF and lower recovery ventricular function, even though their aortic stenosis was relieved by the TAVR. And this is a smaller study, but again, looking at the same thing. Patients who had TAVR, EFs all 55%, essentially normal EFs. If you developed a left bundle branch block or needed a pacemaker, your ejection fraction went down at a year, even though your aortic stenosis was relieved. Patients who didn't have conduction abnormalities, their EF went up, as you would expect it to when you relieve aortic stenosis. What about the ugly side of TAVR that I talked about last year? There's some bad complications that occur. Femoral artery, iliac artery on the stick, rupture of the ventricle at the aortic annulus, tamponade, coronary occlusion, valve dislodging and going everywhere that you don't want it to go. And we've had pretty much most, if not all, of these complications at Washington University. And actually, these have gotten better. As our experience has gotten better, as delivery devices have gotten better, but they haven't gone away. But TAVR is getting better. Here's some of the data from this year. The PARTNER 2 trial, which again we were part of, was reported in April of 2016, looking at patients who had moderate risk, 4 to 8% risk, according to the STS. And they were randomized to either getting a TAVR or a surgical AVR, and their outcomes in terms of death or disabling stroke at 2 years were similar between the two groups. But even though the valves have gotten better, our sizing has gotten better, patients who had a TAVR continue to have a higher rate of perivalvular leaks and valvular regurgitation, with 22% having mild, which we already know can create a problem even though it's mild, and about 4% who have moderate to severe, and patients who develop AI do worse. So the problem hasn't really changed. We got better at putting TAVRs in, but there's still a problem with AI. And that's the graphs from that partner 2. You see that outcomes are pretty much similar. The brown and the red represent patients with mild to moderate or severe AI. And you see surgical patients have very little. TAVR patients have a lot more. The partner 1 reported 1-year outcomes. This reported 2-year outcomes. And you see that at 2 years, there's more patients developing AI because these valves are probably not perfect when they're finished, and they actually get worse with time. And when you look at mortality, it's not good if you develop AI. And there are a few caveats with partner 2. You have to remember the average age is 81. About 18% of patients were dead at 2 years, regardless of what happened. So we really don't know what the long-term outcome of a TAVR would be if we start to put it in younger patients. And this is a study that showed that at least in moderate risk patients, if you cannot go up through the femoral artery, a transthoracic TAVR, whether it was through a sternotomy or through an apical approach, through a thoracotomy, did actually worse than surgery. So if you have an older patient who's at moderate risk and they have peripheral vascular disease, they probably should have a surgical AVR. And this is the Medtronic trial. So they updated that. They reported initially 1-year outcomes. They haven't reported their moderate risk or low risk trial, but they updated their trial, again reported in JACC in April. Now they have 3-year outcomes. And again, if you remember, these were patients who were at higher risk. They determined the average STS risk score of 7, who were randomized surgery versus TAVR with a Medtronic valve. And at 3 years, their outcomes are still better for TAVR slightly than surgery. But again, at 3 years, the degree of AI is higher in patients with TAVR, with up to 7% of patients having moderately severe AI. Mild AI occurs in about 50% of patients, whether it's valvular or perivalvular. And the pacemaker rate is still high, even though we're supposedly getting better at implanting them. 28% of patients require pacemakers in that trial. And the average age, again, is very old at 83. And again, that's from that study. If you look at AI visually, none or mild, basically in the green color. This is surgical AVR. Most of it is none. Some blue with mild, and you look at the TAVRs, mainly blue, mainly moderate and severe. And this is a report that was non-randomized by a very good surgeon who does a lot of TAVRs from Emory, of the essentially the best valve out there, the SAPIEN 3, the newest iteration of it. It was a non-randomized propensity matched comparison, if you believe in that, but it's not randomized. They went up transfemorally, and it showed that at 1 year, a transfemoral TAVR with SAPIEN 3 was slightly better than surgical AVRs, but at the cost of continued AI, both mild, moderate, and severe. So even in the best technology, we're still having issues with AI. And again, transapical had a much higher mortality than surgery. So, TAVR is getting better. Like I mentioned earlier, the SAPIEN 3 is the newest generation of Edwards. So if you're in the community starting a TAVR program, that's what you're going to be implanting. It has less perivalvular leak, but because they made it bigger and stick into the ventricle more, it has more higher pacemaker rate. The core valve, the Medtronic valve, they tried to make it better, and their commercial valve is now the Evolute. It's a little lesser profile to reduce the incidence of pacemakers, and now they have higher perivalvular leaks. So you can't have both at this point, at at least with the valves we have. But TAVR is definitely getting better technique, better sizing. There are a lot of sophisticated reconstruction, 3D imaging by CAT scan to tell us the exact size, preoperatively what we're going to use, angles, deployment angles, so the valves are being deployed better. We're not losing valves and embolizing them, et cetera, or rupturing ventricles because we're undersize the valve and then we blow it up really big with a balloon to eliminate the AI, and then you rupture the annulus and then the patient is dead. But despite that, I still say TAVR is not dead. So here we're going to look at some studies from Europe where TAVR really has the highest penetration rate. In Denmark, Eastern Denmark, they reported this again in May of 2016, just last month. In Denmark, at least 35% of AVRs are done TAVR. And if you have an isolated AVR, 45% of them are done with TAVR. And in their area where it's sort of centralized healthcare system, patients over 80 years of age are referred for TAVR. Anybody with a higher risk of 6% or higher is referred for TAVR. But despite this very heavy TAVR use, we'll see that the number of SAVRs, surgical AVRs, has actually increased in but except for the last few years where it started to decline. But as TAVR volume was going up, surgical volume was going up. And that's because patients are aging and they're being referred more for evaluation for TAVR and then end up with a surgical AVR. And this is again from that Denmark study. If you look over here, these are patients who either had a TAVR and stent their coronaries or surgical AVR and a CABG. You see that there's more patients having TAVR and PCI. But if you look at SAVR volume, they started off 319. Last year, they did 343 surgical AVRs. So surgical AVR is certainly by no means dead. In fact, their surgical volume went up. They just happen to be doing a lot of TAVRs as well. And when you look at the isolated AVR in Denmark, again, the same thing. 45% of isolated AVRs are done TAVR in Denmark, but when you look at the absolute number of surgical AVRs, they started off at 206, peaked around 230, back down to about 202. Germany, which probably has the biggest penetration of TAVR in the market of any country in the world, where the number of TAVRs has surpassed surgical AVRs when you look at all AVRs. In Germany, isolated AVRs without CABG or PCI. So even in Germany, the age profile hasn't changed. These are implanted in people who are old, 80 years old or higher, and the number of surgical AVRs has only declined slightly at 12%. So are the ugly side of TAVR, are the problems solved? The AI, paravalvular and valvular, we've gotten better at it, but it continues to be a problem for these patients. Stroke rates and embolization, we probably got better at it with better delivery devices, but it's not perfect. Pacemaker requirement remains a problem. If you're going to fix AI and put more stuff around the annulus, stick it past the annulus, you're going to create bundle branch block and pacemaker needs. Longevity, it looks to be bad, and I'll show you some recent study about that. If patients live long enough to reach longevity, it's not going to be there, and cost continues to be a problem. So durability, again, the big unknown. Most patients implanted with a TAVR across the world are older people who just die of other causes or die of AI or whatever it is that is going to kill them. There are very few patients who are alive at 5 years post-implantation, and you have to remember that a TAVR is still susceptible to degeneration, both calcific and others, degeneration from endocarditis, and occasionally there have been reports of embolization of a TAVR early after TAVR with CPR. And these are examples of TAVRs that have been explanted for calcific degeneration. So they're there. They calcify, they get endocarditis. And here's a new problem that was just reported last year in New England Journal of Medicine. And this was a report of 4-dimensional CT scans on 3 studies that involved TAVR. One was a randomized study of the St. Jude valve versus the Medtronic TAVR, called the Portico valve, and 2 were registries, basically Resolve and Savory of TAVR valves. And they did 4-dimensional CT scans, and what they found that in the Portico valves, where they scanned both the St. Jude valve and the Edwards valve, up to 40% of patients had reduced aortic valve leaflet motion. 43% for the Portico, about 43% for the SAPIEN XT, which is the 2nd generation of the Edwards valve. So 40% of these patients on 4D imaging, none of these patients had any issues by symptoms, but on 4D imaging of the valve, the leaflets are not moving well. The good news is, and this was also noted in the registry data where they were following patients long-term, not in a study, with rates is about 14% in those patients where the valve was abnormal on a 4D image. The good news is this seems to go away, so if you've developed reduced leaflet motion on a 4D CT scan, if you're placed on Coumadin, normal leaflet motion recovered. In one patient, they stopped the Coumadin and rescanned them, and the motion became abnormal again. So now some people are talking that patients should be placed on Coumadin. So that's just perfect. You got an old person that you put a TAVR in that you may have to chronically anticoagulate them. That is not the recommendation right now, but some of these valves are not working well on 4D imaging. And these are some of the 4D images where one of the leaflets is stuck. These patients have no clinical symptoms, at least that we don't think they are presenting with clinical symptoms. This was just 4D imaging as part of the studies. And this was just presented about 2-3 weeks ago. EuroPCR is the European version of an interventional cardiology meeting, a big meeting, where they followed 704 patients who had a TAVR in Vancouver, Canada, and Rouen, France. Out of those, they excluded patients who died within 30 days or had early TAVR failure within 30 days. They also excluded a bunch of other things. Ended up from 704 patients with 378 patients who they reported on. Out of those 378, 100 patients actually lived more than 5 years. So if you live at 5 years with a TAVR, 35% of those patients had valve degeneration, which was defined as moderately severe AI or AS. Remember, these are people who are in their 80s. If you live 8 years past your TAVR, half those patients had severe AS or AI again. And again, so these are older people. So the conclusion was, if you have 50% failure rate at 8 years in older people, the failure rate is likely to be worse in younger patients. And while degenerated valves do not go bad, do not necessarily develop outright failure, nor do they have a high reoperative rate, because basically these patients at this point are in their late 80s or 90s. Nobody's operating on them. They're just seeing them and waiting for them to die of valvular heart disease. But it does present the problem. It's a signal that there's a potential problem with TAVR, and we can't just extend it for the lower risk patients and younger patients. And this is from a quote from Dr. DeVere, who is an interventional cardiologist in Vancouver, publishes a lot about TAVRs, says, I think we have to be careful before we move forward toward lower risk patients with Transcatheter valves. Somehow we can say this is not unexpected, but yet the durability question didn't play a major role in octogenarians. It will play a role in the younger patients. And the take-home message was, I think we all need to remember, and we need to remind our cardiology colleagues, is we need to understand that when you target younger patients with lower risk profiles, many of those people are going to survive and out-survive their TAVR device. So you say, well, so what? If they outlive their TAVR device, we'll just put another TAVR in the TAVR that failed. Well, we don't have any data on that, but we have some data on TAVR in failed surgical bioprosthetic valves. Again, reported from Dr. DeVere in Canada. They reported on 459 patients in 55 centers across the US and the world that had a TAVR implanted in a failed surgical AVR. And they grouped them as patients who had a surgical AVR that was small, considered 21 size or less, moderate sized AVR, 23, that was the only size in that intermediate group, and patients who had a large valve implanted in the past, 25 or bigger. And the results at 1 year, 7.6 mortality, at 1 month, and 17% of these patients were dead. I don't know about you guys, the surgeons in the audience, but my operative mortality for a redo surgical AVR is not 7% at a month, nor is it at 17% at a year. That's why we've been implanting a lot more bioprosthetic valves, because the data on surgical redo AVRs is pretty good. But if you put a TAVR in a dying surgical AVR, the mortality is not great, and it's particularly bad if you put it in a small valve. So if you break it down, patients who had a small surgical AVR, 21 or less, their mortality rate was 25%. 19% if they had a 23 valve. And if you remember, just think back empirically, how many 25 valves or bigger do you see your surgeons put in? Not a lot. Most patients have 23 or smaller. In fact, most patients are 21. And those patients don't do well with TAVRs, particularly if the problem is aortic stenosis in the failed bioprosthetic valve. So we know TAVR in a failing surgical AVR is not great. We have no clue what a TAVR and a TAVR and a TAVR will do, but it's probably going to have high gradients. It's probably going to have AI on top of high gradients. So when you put in your first valve, first TAVR, you may have some AI, you don't have AS, but now you're going to put a TAVR and a failed TAVR, you're probably going to have AS and AI. Not great. So I think the notion of implanting TAVRs in a low-risk or young patient and relying on the assumption that many of my cardiology colleagues are going around saying that, hey, when this valve fails, we'll just put another TAVR in, is really not going to be viable. Oops, backwards. What about the cost of TAVR? I mentioned this last year. The cost is about $30,000 for one of these valves. DRG for an AVR on average is $32,000. So the hospital doesn't like us doing TAVRs because they essentially lose money in the operation. They make money on the CT scans and other follow-up studies, but they take a good profit center away from the hospital. And cost is a factor in TAVI utilization in Europe. If you look at the study where they looked at TAVR per population, so this kind of adjusts for the different countries' population, you see certain countries, Germany, France, Switzerland, Denmark are high. Certain countries like Ireland, Spain, Portugal are very low. And this was presented a few years ago, and it seems to be related to how these are funded. In Germany, in some of the more popular centers, there's a specific DRG for TAVR. So the government pays a certain rate to the hospital for every TAVR. In certain centers or countries like Ireland, Spain, Portugal, the TAVR cost either comes out of the hospital budget that the national government gives them, or they pay them for an AVR, and if the hospital chooses to do a SAVR, they make money. If they put a TAVR in, then they break even or lose money. So in those countries where it's not reimbursed at a higher rate, there's less TAVR penetration. So cost is a factor. It's not a factor in the US just yet. So again, the constrained versus TAVR specific system, and you see that countries that have a TAVR system, TAVR payment, do more TAVRs. So in my opinion, will TAVR be the valve of choice? I think it is in the high-risk patients with a STS of over 8%. It likely is going to be if they have favorable transfemoral access. In the moderate-risk patients, it's likely to be the valve of choice if they're really elderly, and you don't expect them to live more than a few years, or they have a poor performance status where they can barely walk. In the moderate risk patient, I don't think it's going to be the valve of choice if the patient is young or it's an older patient who has a decent life expectancy. And I think in the low risk, less than 4% STS, we really have no data. Trials are beginning, but I don't think those trials are going to be favorable to TAVR. So in conclusion, I'd say that as the population ages, there's going to be many patients with aortic stenosis that will need treatment. I think surgical AVR remains the standard of care and will continue to represent probably 50% or more of AVRs, even in the biggest markets of penetration of TAVR. But TAVR definitely has a role. We really don't want to be operating and trying to get these 85-year-old ladies through an AVR, send them to a nursing home. Those patients probably should have a TAVR and avoid our headaches and post-op care. And I think the presence of TAVR will generate more referrals for us. I think surgeons should continue to participate in TAVR trials and TAVR programs because we do need to maintain a role in treatment of aortic stenosis. We need to maintain a role in percutaneous technology because there are new technologies coming down the pike, whether it's mitral valve clip or other things. And we need to keep the TAVR team and the cardiologists honest and give them our true opinion. And then I think you make a decision based on common sense. I showed these pictures. So if you have this little lady, she's fine. She's got severe AS. But look at her skin, look at her, she's going to do horrible with surgical AVR. If you do her, she'll end up probably in a nursing home. On the other hand, you have an older patient, he's in his 80s, got a few comorbid conditions, but the guy's a party animal spinning discs, and that patient should probably have a surgical AVR. He'll do fine, and he's not going to have to worry about a pacemaker or AI. He's not going to have to worry about relieving his aortic stenosis, but still having class 3 congestive heart failure because he has AI and a pacemaker and a very, very thick ventricle that's non-compliant. And that's it.